Good afternoon, everyone. Welcome to Planned Parenthood and Roe's session on empowering women through virtual healthcare. My name is Dr. Melynda Barnes. I am SVP of Medical Affairs and Research at Roe. Roe is a digital health company that powers 3 digital health clinics, Roman for men's health, Rory for women's health, and Zero for smoking addiction. We also have a network of digital pharmacies to help increase access. I'm very proud of the fact that Roe serves at least one patient in 98% of all healthcare deserts throughout the United States, and we serve patients in every state plus DC. So we are incredibly proud to partner with Planned Parenthood and welcome our esteemed panel for an important conversation about women's healthcare. As we all know, women face many challenges when navigating the current healthcare system, from lack of access to not having their health issues heard or understood. We all know as well that when women have access to high quality care, not only do they benefit in terms of increased and improved quality of life, but also their households benefit as well. We've seen the benefits of virtual healthcare firsthand with COVID-19, and we're getting a glimpse of what is possible if we unlocked its full capabilities to address many of the barriers that women and frankly all patients face when it comes to getting the healthcare that they need. During today's session, we will focus on technology and explore how technology can help expand access and improve equity to advance women's health and as a result, their social and economic opportunities. Before we dive in, let me answer just a few questions. So we will have Q&A at the end. It will be the last 10 to 15 minutes of the session. If you have a question, please type it into the Q&A feature in Zoom. I will be multitasking and taking a look at the questions as they come through, and we'll be selecting questions for our Q&A session at the end. So let's get started. Let's meet our panel. So panelists, please share your name, your role, and a brief snapshot of what you do and what your organization does. And let's start with Kevin.
Hi, everyone. Good morning, good afternoon, depending on where you are in the country. Kevin Williams. I am the National Director of our digital products team at Planned Parenthood Federation of America. Our team works, I am directly responsible for the digital patient experience, and our team works on supporting patients, users, and supporters through their digital journey. And so that's the work we do. Before we get to the other panels, I want to first say thank you to Roe and the organization for helping us organize this opportunity and for me to co-host with, have this discussion in advance of more inclusive conversations around virtual healthcare access. It's really exciting to be here among the 16 panel of medical and health equity experts. I'll tell you, as a technology person, I'm very humbled and honored to be here, where we can explore ways to deliver more inclusive and affordable healthcare to empower and impact the greatest number of women. On behalf of Planned Parenthood and our corporate engagement teams, I'd like to extend a special thanks to the senior management at Roe for their strong support of Planned Parenthood's goals to expand access to affordable birth control and for Roe's pledge to our Business for Birth Control campaign. Thank you especially to Roe's CEO and co-founder, Zach Ritano, and to your communications colleagues, Megan and Katie in particular. Thank you.
Thank you, Kevin. Let's move to Dr. Van Dies.
Hi, good morning and afternoon. I'm Dr. Jane Van Dies, and I am the medical director for Maven Clinic. And we are a telehealth platform for women and families. We help women through journeys of fertility, miscarriage, pregnancy, postpartum, and parenting. We have over 2,000 providers on our platform in 20 different specialties. So we really imagine serving women and their families in a comprehensive way and increasing access specifically to not only OBGYNs, but care providers like doulas and midwives and lactation consultants, all of which could be accessed virtually. And so I'm really excited to have this talk on equity. It's something we as a company have been thinking about and focusing on. And so I'm really just so thankful to be here. Thank you.
Thank you for joining us. And Dr. Shepard?
Hi, everybody. I'm Dr. Jessica Shepard. I'm a gynecologist here in Dallas. And I'm just really honored to be on this panel. And thank you to Roe and Planned Parenthood for allowing us to actually have these discussions. As a clinical provider and seeing many women who suffer from, just healthcare issues, but the inequities that we see and the disparities that we see within healthcare, and as a Black female physician myself, I hope that I can be a big voice and a big advocate for my patients, for myself, and having this dialogue is very pivotal because it allows us to access, one, from a medical care standpoint, but also how we can enhance those resources and that access. So I look forward to discussing some of my experiences and then also answering the questions at the end, and hopefully we can all learn today. That's the point, is for all of us to learn.
Absolutely. And before introducing Dorianne, just wanted to also let everyone know that we at Roe are very lucky we get to work with Dr. Shepard as she is one of our advisors for Rory, and that's our women's health brand. So without further ado, our last panel, Dorianne, would you like to introduce yourself?
Yes, so good morning or afternoon, everyone. My name is Dorianne Mason, and I am the Director of Health Equity at the National Women's Law Center. We are advocates and experts and lawyers who fight for gender justice through the courts and public policy and the media and just generally in society, with a very special and explicit focus on women who are facing multiple forms of discrimination. I'm super happy to be here, and thank you to Roe and to Planned Parenthood for having me.
Thank you. Thank you to all of you again for joining us on the panel, and thank you to the participants who have logged in for the session. So we have a lot to cover. Let's dive right into the conversation. We lost a giant, a hero, an advocate recently with the of Justice Ginsburg. And so we would be remiss to not start with that, with acknowledging her contribution, her legacy, the impact that she's had on women's right and health equity. So I think, the first thing that we would like to touch upon and would love to hear from Dorianne to start with, which is, what is the state of women's healthcare in America today? And what, in your opinion, does the passing of Justice Ginsburg, what does that mean for women's advancement, for women's healthcare, and for our society today?
Absolutely. So I'd like to start off actually with a quote from Justice Ginsburg that provides some, I believe, necessary context. So when she was asked about a woman's right to choose if, when, and how to start a family, she said, "This is something central to a woman's life and to her dignity. It's a decision that she must make for herself. And when the government controls that decision for her, she's being treated as less than a fully adult human responsible for her own choices." And I think that we've seen over the last 50 years what gains can be made when women in this country direct their own reproductive choices. We see higher incomes over their lifetimes, higher educational attainment, better health over the course of their lifetimes outside of just their reproductive health, but better health overall. And these are all attributable to reproductive freedom. But the question before us today is, where are we today? And today we are on the precipice of a series of judicial decisions that will shape the health and well-being of women in this country for generations. Trump has promised to only name justices who would overturn Roe v. Wade. And we've already seen that he's delivered 2 justices that voted against abortion rights, and long-standing precedent in a very recent case. That decision was 5-4. So just barely upholding women's rights and access to abortion care. And of course, Justice Ginsburg was in the majority of that 5. And so if we, as a nation get another Supreme Court justice that is opposed to abortion rights, the court could very well overturn Roe v. Wade or deliver its death by just 1,000 cuts. But it's not just abortion care. It's also birth control. It's also the ACA. It's the integrity of our health systems. It's really our lives. More than a dozen cases relating to healthcare and health equity are either one step away from the Supreme Court or they're already at the Supreme Court. The Supreme Court over the last 6 years has taken up 4 birth control cases. The most recent one decided this past July. And of course, we have the case that holds the fate of the entire ACA that's coming in front of the court a week after the presidential election. And of course, the fate of the ACA means protections against pre-existing conditions. It means Medicaid expansion. It means preventative services. It means protections against discrimination in healthcare. It means all of these things. And we're going to hear it in November. I don't think that it is an overstatement to say that literally the health of our nation is at risk. The threat is not hypothetical. And if you would have asked me a week ago, I would have said almost the same thing. But now that we have a Supreme Court vacancy and one of our staunchest supporters of health and health equity and access to reproductive freedom that's no longer on the Supreme Court, she's gone. I don't think that we could make this any bigger of an issue than what it is. So when we're talking about the state of women's healthcare in America, we are legitimately in a fight for our lives. And that's it.
Absolutely. Dr. Shepard, what do you?
Yeah, that was so well said. I just don't even know what to say after that. Dorian, that was just amazing, because that's what it really is. It's a fight for our lives. And when I look at that from a physician's standpoint and see the disparities that are already occurring, it really reigns true to me, those words that you just said, because now we're at that pivotal point where it could become even worse. And sometimes I think being able to allow women to see exactly what that really means for their health sometimes is very important. Because when you do affect a woman's health, you're not just affecting her health, you're usually affecting a bigger community than just that one individual. Because many times the woman is the nucleus of her family and or community. And so when I think of, from the perspective of women's health as a reproductive advocate and an OBGYN who, specializes in women's health, when I see that the maternal mortality rate is still so high when you think of an industrialized country, we're still like almost to the top, if not the worst. And though that's just disparaging and very frustrating to hear that from a standpoint of a physician who's really trying to deliver the best care possible. So that really reigns true when you think if there's representation that is not enough when you think of brown and black faces that patients can see when we think of disparities, but also the resource and access. As simple as what you were saying about birth control, the access to get birth control and who really gets that access. These are the decisions that are going to, again, determine our future in healthcare. And so when I think of the maternal mortality rate, which for one is, again, almost the worst when you think of an industrialized country, but then when you think of a brown and black woman, they're 2 to 3 times more likely to die in pregnancy or shortly thereafter in the postpartum phase. So we could list a laundry list of how this actually impacts women in their health, whether it's the actual disease condition state, whether it's the access and resources, and whether it's just going down to simple care, the care that they're getting when they do go to get healthcare, what does that look like and how we can change that. So we really are at a pivotal point in healthcare, and right now it's not looking great, it's grim. And so I hope that we can fight for our lives and get to a place where we can start to see change.
Absolutely. And Dr. Bandes, how are you and Maven preparing for the future of women's health, given the state of America right now?
Yeah, I can't back up what Dorian and Jessica have said enough. And I think that to their points, when we think about women's healthcare and reproductive healthcare rights, the access to basic coverage, Medicaid coverage. Over 50% of births in America are covered by Medicaid. And in those states which didn't expand Medicaid coverage, we see marked disparities in healthcare outcomes. And those states are, in large part in the South. So as a prenatal care provider, as an OBGYN, after the passage of the ACA, I saw a marked change in the number of women who were accessing prenatal care. And as Jessica points out, when you take care of a woman, you take care not only of her, if she's pregnant, her gestating fetus, but her whole family. And so her healthcare outcomes are multifactorial, and they have huge footprints. So when we are looking at threats to the ACA, we are looking at threats to access for women for basic healthcare, and those ramifications are wide. At Maven, obviously, we have seen the landscape and tried to fill some of those gaps in care. For instance, looking at the fourth trimester, this is an area of healthcare that ACOG has recently acknowledged has insufficient support for women. Women have hypertensive disorders that oftentimes go untreated in the fourth trimester, and they end up back in the hospital, sometimes with severe complications of preeclampsia. And not to mention 1 in 5 women suffering from perinatal maternal mood, anxiety, and depressive disorders. There's a lot of emphasis in America on the baby. Our policies sometimes are reflective of forgetting the maternal body and forgetting the maternal postpartum body. And so really paying attention to how we support women and their families. And lack of access to healthcare. We know that women go into pregnancy with obesity, diabetes, and hypertension, and that if you don't treat those aspects of a woman's health adequately, they have significant complications in pregnancy and postpartum as well. So expansion of the ACA and providing universal healthcare to women is essential. And we're in a really precarious place right now.
Absolutely. As a woman who just gave birth 9 months ago, I could say that it was shocking to me that I had 1 or 2 doctor's appointments postpartum, and my daughter had, 6 or 7. And after my 6-month appointment, it was like, okay, well, we'll just do your regular, annual visit. We'll see you next year. You're good to go. Yeah, definitely felt the difference between our focus on the baby, but not on the changes that the woman's going through in the postpartum period. Kevin, we'd love to hear from you about your thoughts on technology, Planned Parenthood, the state of healthcare for women today, and how that looks different, and how you guys are planning for that with the recent passing of Justice Ginsburg.
Yeah, I mean, I think, the theme here in this discussion really resonates with us at Planned Parenthood. Obviously, we access to care and making sure that we ensure people are able to make informed decisions about their sexual and reproductive health is a top priority to us, and the role access plays is front and center. I mean, I think we're also in a moment of reckoning, because as we are all thinking about what's going on, it's sometimes it can be a little out of sight, out of mind. And I think that we really need to be thinking about, with women specifically, how health care access and affordability, the critical issue that's behind it. And we have to address it as a nation, and thinking around this gap on gender, and thinking around the work that we need to do there. I think a lot of the other points my fellow panelists have brought up are front and center to our discussion, but I really think that there's a story there that really needs to be lifted up and continue to be discussed within ally communities and other communities as well, just about the challenging state of what women's healthcare looks like right now.
Yeah, and we know that each one of you have hinted at this, so we'll jump right into it. But we know that college enrollment was 20% higher for women who had legal access to birth control than for those who did not. We know that the number of women pursuing professional education spiked after the landmark Supreme Court cases that made birth control legal and accessible but now that's at risk. We also know that access to birth control pills is responsible for roughly a third of the total wage gains women have made since the 1960s. We know that there is still very much a wage gap between men and women, and especially women of color, and we need that to be addressed. But we know that access to birth control has helped narrow that gap. So my question, and we'll start with Dorianne, especially as it relates to Supreme Court decision, but how has limiting access to sexual and reproductive health care impacted women's health overall with the recent or with the Supreme Court decision regarding birth control coverage? And also related to that, how has limiting access to sexual and reproductive health care impacted women's social and economic advancement?
Yeah, I think starting off with those stats is incredibly helpful. I think that when we're talking about, particularly over the last 4 years, what the consequences of the policies and judicial decisions have been is continually limiting women's access to birth control and abortion access. And the gains that we've made over the last 50 years, as easily as we believe that they are ubiquitous and a part of our lives, they can be taken away. And I think that that is something that is incredibly important for people to realize, that it's, right now we have access to birth control, but the question is, how much does it cost? Does that person actually have access to it? Can they see a provider to get it? If abortion access is legal, does that person have coverage of that procedure or that care? If not, can they afford to pay for it? Is there a provider in their area that can provide that service? So it's a question of all of these different smaller decisions and opportunities that actually impact access. And if we continue to undermine, continue to dismantle, continue to take away these protections, then access to birth control is going to be a name only. Access to abortion care is going to be a name only. And then women are not going to have access to true reproductive freedom, and all of those gains, all of the opportunity, the economic opportunity, the educational opportunity that has come with those protections and those benefits is going to be erased. And so when I'm thinking about, the impact, that's what I'm thinking about, that we have to pay attention to these decisions, these court cases, these policies, these legislators who are, very intentionally taking piece by piece away from the progress that we've made, away from the protections that we should all be guaranteed.
Absolutely. We talk about that at Row all the time, and that's definitely one of the reasons why we started our Row Pharmacy, which is $5 generics, because you can say that someone has access in name, but if they can't afford it, they don't have access. And so I think that we're all nodding our heads and that's basically the point of the talk today, is how technology, hopefully, can be a solution to get more women access, because we're not limiting them geographically. Hopefully costs to the healthcare system can go down. So we'd love to hear from Kevin in terms of Planned Parenthood. We know this is a part of your mission, and so would love to get your thoughts on this as well.
Yeah, I could literally talk for the whole hour about this. Like I said, access and using technology and educating folks is really, really the important piece of this. When we think about, in the Planned Parenthood, we have tools. We've created digital products like our chat products that are really evidence-based and really set up individuals with the right information to make informed decisions about their lives. And thinking about how that plays out in the digital world, obviously we have to think about the access to devices. What are the challenges in those areas? I think in COVID we learned a lot, and we'll get to that, talking about some of the pros and cons of what's working and what's not working in that space. There is a real opportunity the role technology plays currently right now, because that's where we are, meeting users where they are, and they're on their technology devices, and hoping that where there may be physical access constraints access to care, that we can use the digital platforms and other tools to connect audiences with the care and information that they need. So that's like a top of mind for us. And as we work with our partners at our health centers delivering care, connecting our tools and products to the care that they deliver to folks is really important to our work, thinking around how we manage navigating through some of these obstacles that we all know about.
Yeah, and you brought it up, and just go ahead and jump into it. But I think both COVID-19 and the Black Lives Matter movement have continued to not just shed a little bit of light, but really put a spotlight on how longstanding systemic racism has shaped and negatively affected health for Black and Brown people in our country. I want to direct this question to the physicians on the panel, Dr. Van Dissen and Dr. Shepard. In your experience as gynecologists, as obstetricians, for Black and Brown women, how has systemic racism impacted their health? Oh, you guys both came off mute at the same time. Dr. Shepard.
I know. Yeah, that's fine. We were like, who's going to go first?
I know.
No, I think that it's one of those things that you really have to make points about. And I think that comes from, obviously privilege, but even as a physician, even within the physician community, it still requires these types of discussions and allowing people to see the evidence of what we know, what's presented in studies, what we know with statistics. And I think that it impacts women's and communities' lives so much that sometimes when you're not in those communities, it's very hard for you to share those experiences and see those consequences. And that's what I think, like you were just saying, Dr. Barnes, during COVID, is we've seen that privilege. Whether it doesn't even, at this point, it didn't even matter with economics. Obviously, you see a disparity more with Brown and Black people. But what I did find is that equity, it's always going back to that equity of healthcare and how that's able to be provided and how that access sometimes can be completely cut off. And so to see mothers with their infants and also during pregnancy not being able to get the care that they need, whether it's from a medication that they can't afford. And this goes back to, I'm newly in Dallas and was in Chicago. And there I did so much work with South Chicago because there's a very, segregated in Chicago, and seeing how many people just to get to me. And I worked at the University Academic Center to get to our actual hospital to have a visit. That could require women taking 2 buses, 1 train, just to get to an appointment. And then possibly, because the access and care that they have, possibly waiting up for an hour, hour and a half just to see the doctor. And so sometimes you really just have to label it for what it is and allow people to see that struggle. So maybe they can internalize that and put more thought to it on why it's so important when we're now bringing it to high level of, the Supreme Court vacancy, what that means. So sometimes it really means just really peeling back the layers and simply labeling it from an experience perspective on how that impacts all of us and how that can impact a community and why that is so important today when we're faced with some of these challenges with a Supreme Court vacancy.
Yeah, Dr. Mendes.
Yeah, I just, I read a quote the other day. It's a statistic I hadn't thought about, but W.E.B. Du Bois in 1906 pointed out that social conditions, not genetics, impacted the health of Blacks. So the federal government, the US federal government in 2010 finally recognized and defined social determinants of health. So only 104 years for for us to recognize that it's not genetics, that it's not race, it's racism. 1 in 5 women report experience, 1 in 5 Black women report experiencing discrimination in accessing prenatal care. We fundamentally have to look at all of the ways that women interact with the healthcare system, and how do we make each of those encounters more equitable? How do we use an equity lens? I work on labor and delivery, and I see sometimes some of the microaggressions happening in real time. I think we also have to acknowledge the history of obstetrics and gynecology. ACOG did come out with a statement about 2 weeks ago acknowledging that their history is actually steeped in racism and some misogynistic policies and procedures. We have to own up to who we are and how we've treated women. And then we have to reimagine what a future without race and misogyny looks like. And I think, that's where we are right now. But I'll be honest with you, we have a lot of work to do. We have a lot of work to do, but it does start with truth telling.
Absolutely. I mean, yeah, I just, my background's in ENT and facial plastic surgery. And I was just looking at just now a textbook that a medical student created for other medical students, looking at what dermatologic manifestations of disease look like on skin of color, because all the books pretty much show what a rash looks like or eczema looks like on Caucasian skin. And so people, some very real, tangible example of Black and brown people not getting the same healthcare because of the way that the system has been put into place, and starting even with medical education. We've seen that COVID-19 has really, changed the tide on virtual care. We know that from a recent study that Black patients were more likely than white patients to use telehealth because of the pandemic, in particular young Black female patients. This is a question for everyone, and we can start with Kevin, but how has COVID-19 helped and or hindered virtual healthcare and women's access to healthcare?
Yeah, I mean, I think, before March, when talking about telehealth or telemedicine, it sounded like a nice to have, it was like a popular fun thing that, hey, we were all thought was kind of cool on some level. And, that quickly changed. I think it helped in the sense that it kind of optimized the need for telehealth. It actually validated, some of the things that we've been talking about related to telehealth. I think it helps manage some of the physical distance required and constraints required to having to go to a physical location, the time required, costs and things associated with that. So there's certainly benefits to that approach. I also think, when we think about policies, some of the policies were relaxed as a result of COVID, and which allowed for increased access. Just so prior to COVID, only around, I think it was around 11 states allowed for telehealth services to accept medication as a form of insurance. And so it creates some opportunities there. I mean, I also like to highlight, when you say hindered, like the thing we don't want to talk about is there's a real digital divide that exists here in this country and within communities. It exists, it has existed for a really long time, and it really has shown up exponentially during this moment. We're seeing the disproportionate impact on Black and brown communities. So like, that's not even up for debate, but it just goes even further. And then when we think about privacy, real challenges associated with privacy. It's one thing to have a private moment with your doctor or provider in an environment versus trying to take that on. Privacy at home looks very different. And so at Planned Parenthood, obviously privacy is a top priority for us. And so we're always thinking about that when working through our solutions for managing support during COVID-19. And so, and I think the only other thing I would say is one of the bigger challenges, and someone else will probably hit this, it delayed care for a lot of people. And so as a result of that, I think I have a statistic that says 1 out of 3 women reported that because of the pandemic, they had to delay or cancel a visit to a health center provider for some sexual related health care, or had issues with their birth control. So I definitely think that there's some pros and cons, but just a lot to say there.
And Dorianne, I saw you enthusiastically nodding about when Kevin brought up about the digital divide. So what are your thoughts?
Yeah, Kevin, I think that was a perfect explanation of the difficulty that we're in now and the opportunities that this moment is presenting us. When we talk about health equity at the Law Center, we talk about very explicitly all of the barriers that can be erected to care. And in this moment with COVID-19 and the rise of telemedicine, there are opportunities for us to take some of those barriers down, right? Those barriers are now removed. When we talk about transportation to, I think Dr. Shepard earlier talked about the buses that people may have to take, right? Or if they don't have bus fare to even take that bus. Telemedicine allows people the opportunity to now have access without having the barrier to care that transportation can sometimes become. But then when we think about another barrier, when we think about childcare, right? So what does it mean to be living and serving as a caregiver, and then also trying to access your health care while simultaneously having to address the needs of potentially your children or any other adult that you are providing caregiving services to. So I think that there are most certainly opportunities and ways that we can innovate that reduce some of those barriers to care that people who are less resourced many times experience. But there are also situations outside of just the digital divide, but also what does it mean to be balancing right now, care for yourself, care for your family, potentially working or not having work and then experiencing the stress of economic insecurity. And how does that then impact your ability to engage in telemedicine fully and completely? So I think there are definitely, opportunities, but there are difficulties as well.
Yeah, and Kevin also had a nice pearl in there about women reporting the needing to delay care when it came to sexual health. And we know that in June, it was reported that 29% of white women, 38% of Black women, and 45% of Hispanic women were having a difficult time accessing birth control due to limits in in-person care. We know that this is where virtual solutions can help. So I'll do a caveat question for Dr. Van Dis and for Dr. Shepard. But what roles have virtual healthcare and technology played during the pandemic specifically to help address these healthcare access barriers for women, and in particular for sexual and reproductive healthcare? Let's start with Dr. Van Dis and what you guys are doing over at Maven.
Yeah, so we asked our providers to increase their availability, and we saw a 6 times increase in provider availability. We brought our wait times down to less than 15 minutes. We also had a partnership with Mass Health, which is the Medicaid program for the state of Massachusetts. And so we were able to offer free telehealth to 1.8 million lives in Massachusetts. So we really know that part of the ability to access care is timeliness. Obviously, Kevin pointed out really important barriers around the hardware and the software, whether it's the connectivity or the device. But once you can get there, we at Maven tried to lower a lot of those barriers.
And Dr. Shepard?
Yeah, I think during the pandemic, if you think just of traditional medicine going from paper charts to electronic medical records, and then we got stuck there a little bit as far as who would use telehealth. or virtual healthcare. And during the pandemic, we definitely saw a significant increase in, as far as providers having to use that format in order to communicate with their patients, specifically because it was really trying to mitigate any transmission and therefore not having a lot of people in the office setting and really reserving it for emergency type of situations. And then in the instance of obstetric care, we were able to, for normal pregnancies, really kind of fine tune and decrease the amount of in-office visits that they had by interspersing virtual care, because these, again, are patients that still need to be seen. I found that specifically with reproductive care, that this was one of the highlights for us during the pandemic, or as we transitioned into in-office visits to virtual care, is that it allowed people to feel safe. That's one of the things that you want to convey as a healthcare provider, is that your patients feel safe. And this allowed patients to feel safe because now in the comfort of their home, and not necessarily if they have any immunocompromised conditions that really did not allow them to come outside. This provided that access. And also for patients specifically with any issues like chronic pelvic pain, that's a lot of what we see too in our office, is that it allowed us to, because we weren't allowed to do surgeries for some time, about a good 6 weeks, we're not able to do elective procedures, is using virtual care as a way to check in actually with these patients, and any patient that needed a more reassurance for whatever condition or disease state that they have. Reassurance is a big part of healthcare, and this allowed us to really connect with our patients outside of having that office visit. So there were a lot of things that I saw in a positive light, that virtual healthcare is able to help us, one, continue the medical plan that we had for this patient, as well as being able to reassure them for whatever we needed to do for their condition.
Absolutely. So it's 1:43 already. So let's talk about how do we get there? What barriers? We've talked about this a little bit, but how are we going to address the barriers that exist for realizing the full potential of virtual healthcare, especially for women? The goal with virtual healthcare, I feel like there are a few. One could be decreasing costs and improving the experience, improving the efficacy and effectiveness of healthcare. But the number one thing that a lot of people have focused on is access. So would love to have Kevin kick off on, and you talked about it already, but like barriers that you see for hitting virtual care's full potential, and what are some of the solutions that can be done to address those barriers in the near term and the long term?
Yeah, I mean, I think the good thing about moving to a virtual world is you're able to scale faster, and you're able to, I think, normalize the actual conversation around what telemedicine is and what a telehealth visit looks like. I mean, I certainly think that, for us at Planned Parenthood, that's important because, we provide a whole host of a whole range of services. And so to normalize services, like STI testing and treatment, gender affirming hormonal therapy, PrEP, just an extension of all of the work that we're doing, emergency contraception, and bringing that into a virtual space, along with making sure that you're supporting people in education. And for us, that's through our chat tools, where we've leveraged artificial intelligence, and we have live educators. I think I spoke about this earlier. You create a consistent messaging around these areas, these topics of interest, but at the same time, we need more research. We need more information to understand what are some of the constraints that folks are having. So we need to build better tools. And so working in technology, we build something for the billion people that will come and hopefully use our product. I think inclusive design and thinking about marginalized communities and people who need it the most, we get to those groups of people last. I think we really need to have a strategy where we are doing the huge populations and the folks that really who need it the most. And I think that requires us to look at the technology that we put out and see how compatible is it with what folks are experiencing in their lives, and and sometimes that's on language, sometimes that's on functionality of the product, devices, access to bandwidth, to broadband. And the one thing I just want to highlight is, like, in all of this, one of the great things that has happened is we're offering telemedicine via the phone. Like we've reverted back to where we had a constraint where a video visit wasn't available or necessary. We've gotten back to where we were before, where we can actually have a conversation with folks on the phone, and that's improving access. And so just thinking about how all of these pieces roll up to a broader strategy about how if we're going to say it and really mean it, we really need to be thinking through this end to end on how we can make better products and support people in according to their needs and expectations.
Absolutely. Again, I know we talk about that every day at Row, and it's something that we're really passionate about as well. And I think, I know that's one of the reasons why our two organizations work so well together, is that we need to think about the marginalized communities first, because they're often left behind. And we can see when we look at, Black and Brown communities, LGBTQ, they're the communities that are suffering disproportionately with different conditions, especially again with the pandemic and COVID-19. So we're running short on time. So before we turn into Q&A, I just wanted to share a quote from Helen Keller and get some final thoughts from you all. But Helen Keller said, "Alone we can do so little, together we can do so much." And we know that that's a sentiment that we need now more than ever. And so that brings me to my final question, and I'd like to start with Dr. Van Diest to talk about allyship. But how can the government, the healthcare industry, businesses partner to advance women's health through virtual healthcare and more broadly? And what are some of the calls to action for people who want to make a meaningful impact?
Yeah, well, I think first and foremost, we really have to talk about who's paying for this healthcare, and making sure that in the expansion of telehealth services that we talk about coverage parity and we talk about pay parity. As Jessica probably knows, there are practitioners out there who are doing telehealth, and they're saying, I'm not getting reimbursed for these efforts. So coverage parity and pay parity are essential, and those are government actions. Obviously, I'm going to say we need to expand Medicaid. I'm going to say that we need to support the Momnibus bill that expands Medicaid for the postpartum period. And also, I think we need to get in touch with our partnerships with community services that are already doing the work and expanding those services. So in the postpartum period, that might mean lactation support. It might mean mental health support. I can speak personally. It's very, very challenging to access mental health care providers. Florida has only 16% of the mental health practitioners that it needs, and all of the other states are close behind. So when we talk about expanding access and partnership, we need to recognize where there are significant gaps in care. 50% of US counties don't have an OBGYN. So, and you read every day about a labor and delivery hospital in a rural area that's closing. So we need the support of government. We need to work alongside them and ask them to expand services and pay for them. And then we also need to recognize the communities that are already providing some of this care and bolster them and support them. Those are, yeah. I will say one thing we at Maven are doing is we are trying to give our patients the opportunity to match with a care provider that meets their needs as far as language, race, ethnicity, as well as specialized services like trauma-informed care. So recognizing that Black and Brown people especially might benefit from having care providers who reflect their background and will likely see better healthcare outcomes.
Absolutely. Thank you so much. We've got some great questions in the chat, so I am going to start that. I think the first one I will direct to Dorianne, and it's from Jillian, who asks, how do you recommend we stay educated on the policies that affect women's healthcare? How can we really learn about which judges, politicians, et cetera, are actively trying to make healthcare easier or more difficult for women?
Yeah, I think that's a great question. There are incredible organizations that put together information and fact sheets about judges and current decisions or cases that are in front of the court that would impact women's access to healthcare. And so I would definitely say to check out the National Women's Law Center, so where I work, check out Planned Parenthood, check out other organizations that care about reproductive justice, rights, and health and freedom, and look at what materials they are providing, because we have to keep up with these things, right? So like as a part of the work that we do, we are tracking the progress of our rights and where those rights are threatened. And so definitely connect with an organization like that to keep abreast of what's happening. I will also say, and this is a broad topic, but relates to this question as well, is that I think that it's important for people who care about reproductive justice and reproductive rights to talk to other people about how connected all of these issues are, right? Like health justice is reproductive justice, is food justice, is environmental justice, is criminal justice, is racial justice, is all of these things. And so if you really care about reproductive justice and freedom, if you really care about health equity, you have to look at how all of these decisions that our policymakers are making, and that our legislators are making, and that corporations are making, are impacting how people access these rights and how real those rights are. And so, don't just keep abreast of, what the judges are doing, but act in the affirmative, right? Like, so push the people that are around you to understand how connected these issues are and to be doing things in their own individual lives outside of just pushing our legislators and our courts to get it right.
Absolutely. Thank you. Thank you so much for that. And for really, I think that's a nice take home point for people that are here in the session, is that this is all connected. And so we have to hold people accountable, like you said, not just the judges and the politicians, but the corporations, businesses. Have a question for Dr. Shepard. So Megan writes in, OBGYN visits are often performed in person due to the nature of physical examinations. While virtual care promotes greater access, how do you recommend we address virtual care quality gaps? And I'll put a qualifier on that, is do you feel like there is a gap in quality of care when it comes to virtual versus in person?
I think that's a great question. And kind of to piggyback on what Dr. Van Diest was saying earlier about how we actually have to make this virtual healthcare more of an impact, is we actually need to do a lot of education with healthcare providers. I think that, we're very well versed in it, and we see the positive benefits of it, but there are a lot within the healthcare community that still not have fully adapted to how this works. So there does need to be an education piece on that end as well. But to go back to the question as far as specifically for women's healthcare, because a lot of the visits need to be an exam, I think this is where I actually saw how that can transpire through, as we were going through COVID, is that a lot of what we do has to do with like a history and a physical, or a history portion taking, which means we really need to get a good story first of all the facts, all the experiences, and really trailing down what that person is experiencing before necessarily going right into the exam. And then again, bringing that patient in for an exam. So now that could transpire over a course of 3 visits, 2 being telehealth and 1 being in person, is also the follow-up. So for example, when we did surgeries during the time of COVID, when we were really trying to decrease the amount of people that came in the office, I had a lot of people who actually traveled out of state to have their surgery done, and we were able to do a lot of their preoperative work virtually. Then obviously they, come to the hospital for their surgery. I mean, who knows? We may be able to do surgery virtually someday. But and then after she was able to go home, then we did 2 of her follow-up visits via telehealth. So there is a way to integrate that type of care. And that's why I want to express how important it is, both on the clinical side that it can be done, and then for people who are asking how to integrate that, it really can be done. And it's not either going to be all one or the other. It really is marrying the two and having that kind of cohesive type of care and visits.
Along those lines, this will be a last question, but I'm going to try to merge these 2 questions together for Dr. Van Diest. But how do you observe digital health innovations, this is written in by Rachel, as being part of the solution in the disparities in maternal morbidity and mortality related to childbirth? And a follow-up to that from Amoy is, what specific virtual tools are you guys using at Maven to help reach marginalized communities?
Yeah, so what we know is that unfortunately some of the comorbidities of pregnancy can affect both maternal and fetal outcomes. So the most common of those is diabetes in pregnancy, affecting close to 1 in 10 pregnancies, hypertension, chronic or preeclampsia, obesity having impacts on pregnant women's journeys as well. So what we're doing at Maven is we're creating high-risk pregnancy journeys and supporting women through these journeys, not only with OBGYNs, but also with diabetic educators. I can't tell you, OBGYNs are often scheduled for 9 to 12-minute visits for OB care. That is not enough time to explain the carb count difference between 4 different types of yogurt. And what is the difference between pasta, bread, and tortillas in terms of their impact on the health. And so you really need the team approach in pregnancy. So you need diabetic educators and nutritionists, you need physical therapists, and importantly, you need mental health practitioners as well. And I think this really is where I've been telling the team that when someone is diagnosed with a high-risk condition in pregnancy, what are the paths that we need to create in terms of addressing their physical needs in that pregnancy, but automatically putting them together with a maternal mental health specialist. Oftentimes women, when they're diagnosed with complications of pregnancy, they feel like they personally failed themselves. And so we need to actually reframe the whole conversation, and we need to support women and give them the tools that they need to be their healthiest selves. And so in terms of how, Maven is impacting communities of color and closing health disparities here, it's really by giving women access to the providers who can help them through these journeys. Obviously, we know that doulas tend to improve pregnancy outcomes, so we have a lot of doulas on the platform, and specifically doulas who might speak their language. We speak over 20 languages, over 30 languages on the platform. So putting together a birth plan or birth journey with someone who speaks your language and who also understands some of the barriers that you've faced in your own health. So meeting people where they are and meeting them with the right practitioner and increasing and closing gaps in care.
Thank you. And we're at 2 o'clock, so please just stay on 1 minute so I can close by thanking Dr. Shepard, Dr. Van Diest, Dorianne, Kevin, and Planned Parenthood for contributing to this wonderful conversation and for their work, or for your work, to advance women's health in America. I want to thank everyone on the line for joining us today and for your very thoughtful questions. Unfortunately, we couldn't get to all of them. And just wanted to let everyone know that you will be getting an email from us as part of this event, was part of our Rose Fall panel series on exploring inequities in healthcare. So you'll get more information on that in an email and via social media. But thank you again to everyone, and I hope that everyone stays safe and well, and thank you again.
Thank you.
Thank you.
Bye.